And thanks to everybody for staying on the penultimate session of this 2.5-day meeting. I'm Joe Brzee from Flu Division at CDC, and now we're going to turn our attention away from push mechanisms, away from helping companies develop the technology, to transfer the technology, to overcoming some of the regulatory hurdles of developing sustainable vaccine production in a country. We're going to turn our attention towards, for lack of a better word, pull mechanisms, to developing the case for vaccination, to developing the demand for the vaccination, and to collecting the data to develop the argument that a vaccine is actually needed in a country. And I think this is the yin and the yang of vaccine production, or sustainable vaccine supply. And I think this is obviously a crucial part of it. We have the fortune today of having two people, the speakers, and additional people in the room that have actually done this before. Flu is not the first vaccine down this pathway. There are other vaccines that have been introduced in the last 10 or 15 years that have had a coordinated plan to bring the vaccine from developed countries to developing countries. Our two speakers today represent two such plans. One's called the rotavirus ADIP, called the Rotavirus Vaccine Program, and one is called the Pneumo ADIP. And these programs were developed as a concept by Gavi in around 2002, 2003, funded to accelerate the vaccine introduction into the countries that could least afford life-saving new vaccines. And so our first speaker, Dr. Marc-Alain Widdowson, is the international team lead in influenza now, not rotavirus, in the influenza division for all our international activities. And he'll give a talk on his previous life working on rotavirus and give us a primer on the rotavirus ADIP. Mark?
Great, thanks, Joe. As Joe said, this is a previous life, so I have to reincarnate myself a little bit. So forgive me if I seem rusty. I've been logged out of my own computer here. Okay, here we go. Great, so thanks everyone for staying on, and thank you to Joe and the organisers for inviting me to come and talk about the rotavirus ADIP. What I plan to do is just to give a brief overview. This is a big project with many partners, including several people in the room. And so I'm just really going to focus on surveillance and, as Joe said, creating the demand for a vaccine in different countries and the approach that we took. So before ADIP came along, what was the situation of rotavirus around the world? And really there was little sustained surveillance anyway. Most of the studies have been burden studies have been done in high-income countries. The laboratory capacity had been limited for diagnosis and typing. Yet, WHO had recognized the likely high diarrheal mortality globally in the mid-1980s. But the interest of rotavirus had still, until the 1990s, has still remained largely the domain of virologists and had not been put in the larger public health perspective. But there was a proof of principle of a live oral rotavirus vaccine that had been established. And this map shows kind of rates of diarrheal or rotavirus attributable mortality in children under 5 around the world, and this can be seen in the poorest parts of the world, Africa and Asia. Southern Asia particularly bore the brunt of diarrheal mortality, or rotavirus attributable mortality. And this was really one of the big driving forces for the ADIP. And so the ADIP, as Joe introduced, was Accelerated Development and Introduction Plan, which was established in 2003 with a grant from the Gavi Alliance. There's a partnership with PATH, US CDC and WHO. And the main mission was to reduce child mortality and morbidity from diarrheal disease by accelerating the availability of rotavirus vaccines that had started to be introduced in developed countries, and to accelerate their introduction into poorer countries. And this is a graph that was initially developed by McKinsey & Corporation, and on the x-axis shows the number of years from availability of a commercial vaccine and its introduction into around the world, and on the y-axis is the millions of doses, and this can be seen here in hepatitis B. Took many years before many developing countries or poorer middle-income countries started to introduce these two vaccines. And the idea for rotavirus was to accelerate this process so that the number of doses globally distributed and administered in poorer countries was brought way forward by almost a decade. And this is shamefully lifted from a path presentation, and basically outlines the paradigm here that we should start off with a safe, effective vaccine, or at least the proof of principle of a safe and effective vaccine, the strong disease burden evidence, and then really two push and pull arms, one which is the available supply and then the demand. And a lot of the last couple of days have been focused on the available supply, and what I'm going to talk a little bit more about is the demand and creating the evidence base to stimulate that demand. And there are many different bits to developing an evidence base. There's cost effectiveness, economic models, impact models, logistics, and of course the actual policy part of actually persuading and advocacy efforts. I'm not going to go into all of this because it would take me all morning. I'm really just going to talk about surveillance. And how surveillance produced a lot of the data that was required to go ahead and move along that path to creating a demand. So what were the evidence? What was the objective of doing surveillance? I mean, one was to develop a global evidence base, to create data that we could get global mortality estimates developed, regional mortality estimates developed, and also importantly local estimates. I mean, I think many countries sometimes look with some suspicion onto other countries' data. They would say, well, that's normal. They got rotavirus because that's country X. We know we don't, but they do. So it was important to recognize that fact that you couldn't necessarily translate data from one place to another. The second objective of surveillance was to advocate, to disseminate the data, and to actually generate people in countries that would be champions, that would actually take ownership of the problem. And usually they'd be kind of relatively high-profile pediatricians or Ministry of Health officials that would then be able to advocate in their own settings for rotavirus vaccines. And then lastly, to create some sort of longitudinal pre-introduction data sets for impact evaluation. And the important thing about these surveillance networks is that they're really multi-partite, multi-partner networks, and this is just a list of the various people that were involved in doing surveillance for rotavirus. And that's clearly important. I mean, it's a network of networks, if you will, that not only there's a network of sites, but a network of people coordinating these sites. And that was important, I think, to get an overall buy-in into the whole from a global public health perspective into the paradigm of introducing rotavirus vaccines. And really the engine for this was a generic protocol which was largely developed by Joe, which was a kind of toolkit to see how do countries go about doing hospital-based surveillance. And so it was relatively straightforward in the sense that it was children under 5. It was relatively simple data collection. One of the main outcomes was simply the percent of children that had diarrhea that were positive for rotavirus. In some cases, we could get a population base and we could do a rate and get some incidence rates, some guidelines on strain typing. And in some cases, like I say, we would do outpatient visits as well, costs, and also rates of interception, which for rotavirus vaccines was also another issue. And really, this slide basically shows that the importance of different countries have different types of surveillance systems. I mean, some can do everything, some can't. Some have have rusted away in a corner for a little bit. But the idea of the generic protocol and a little bit of technical support was that most countries would have the engines to be able to create, to generate some data. And I think that's important. And if you've got countries that don't generate data on a certain disease, that they suddenly start doing it, that actually has almost a disproportionate amount of impact and perhaps puts other countries, neighbouring countries, to shame. So I think it's important that it's an all-inclusive model and not one that just focuses on certain easy to collaborate with countries. And this is a map from 2008. We had over 50 countries doing rotavirus surveillance. Some of the early networks in Asia, again, that was started up by Joe, and I see Roger in the back, Roger Glass. And these were more bilateral networks that started off working directly with academic institutions. And then gradually, as the program matured, And as the reach of the surveillance went global, WHO regional offices became clearly very important, and so we had different colours relate to different regional offices of WHO. And the degree of support and interaction with WHO depended on the country, on the region. So in PAHO, it was really completely driven by PAHO. In other regions, we gave some more technical support. And really the data that generated out of these surveillance networks is really quite straightforward. And this is not for you to look at the numbers, but just to get a sense of the data that these networks were generating. So here, for instance, we just look at the age breakdown. So by age group, the percent positive for rotavirus. And then we have a graph, and we'd give these slides to all our surveillance partners so that they would generate the same type of data in the same type of format. So this is the cumulative distribution of cumulative frequency of rotavirus outcomes. Then we look at seasonality. And then we might compare rotavirus positives with rotavirus negatives, and with the idea saying that rotavirus positives tended to perhaps be more dehydrated than the rotavirus negatives, and gave some idea of the clinical presentation. And then, of course, we'd have some strain data, and the idea of the strain data would be to say, look, the strains that you have circulating in your country actually match very well to the strains that are in the vaccine, or don't match, or at least it gave the Ministry of Health some information on which to make an informed decision. This dissemination of the data, we had this CDC rotavirus, and this is just an example. PATH also had websites and newsletters. This was one that we generated, rotavirus surveillance news. And then also I think important is to get some of this data out in the literature, and there were a variety of, a sequence of supplements and papers. This first one, rotavirus in Asia, focused on Asia. Recently we've just come out with a global rotavirus surveillance, again, which highlights a lot of the data from these countries. And there's a third rotavirus supplement coming out again on Asia, a second phase of Asia that's coming out in vaccine. And then we have these meetings every year to kind of generate enthusiasm. And this table kind of shows, in a summary, the kind of data that that came out of this, and this was in the supplement, in the JID supplement that came out a couple of months ago, and this goes by region and gives a summary of the percent positive, and that's the kind of fourth column along, the percent positive for rotavirus among children presenting for hospitalization with diarrhea, and you can see it range from 32 to 47%. And I think the cumulative weight of that evidence, fed into a lot of the global disease mortality estimates and impact models and cost effectiveness models that were done for the global community, for the world as a whole, which again drove the global agenda for rotavirus introductions, as well as creating data for regions and for countries to make their own decisions. I really wasn't going to talk about vaccines, but this is one of Roger's old slides about different types of vaccines that were in production, or at least were in development at the time that the ADIP started. And there were really the two main ones were the two big pharma vaccines, Merck and GSK. China had also a vaccine that it was using really just for national purposes. And then there were other vaccine candidates that were being developed and still are being developed in India, Australia. And Al-Kapikian had an NIH vaccine model that he farmed out, that he's to developing world manufacturers to create their own kind of homemade vaccine using different components of different rotavirus strains. And clearly you can see from this map is that the lamb here, because it was a lamb-based vaccine in China, is way out ahead, because China was using it for several years. But the two big pharma vaccine candidates, the cow and the human, because one was a cow-based and the other one was a human rotavirus strain-based, really are way ahead of these other strains. But so a lot of the ADIP model was based on the promise of these two big pharma vaccines, with the future promise in the medium to long term of other vaccine candidates maturing and going through licensure and recommendation. There were two concerns, I think, when the ADIP started. One was whether these new vaccines, even the big pharma vaccines, were safe and whether they were efficacious, particularly in poorer settings where previous vaccines had not been. And there were initial trials that were done in mid-income countries, which basically established the safety and efficacy in those settings, and led to a limited recommendation by WHO for Europe and the Americas. But there were still doubts about whether the vaccines would work effectively in poorer settings. But then trials that were initiated and coordinated largely by Kathy Newsell here in the audience showed that these vaccines certainly would work satisfactorily in those settings too, and WHO last year, in 2009, expanded their recommendations. So my last couple of slides are really just to kind of compare flu and rotavirus. And so this slide is basically to look at the similarities. I mean, both have an available vaccine. Both diseases have an available vaccine, which is underused in poorer countries. Little is known of the burden in developing countries. At least this was the case of rotavirus before the ADIP, though may not be high. For influenza, I think we really don't know enough about poorer settings, as has already been mentioned. The in-country perception may be that it's not really a big issue. Yet these are both viruses which are ubiquitous and democratic. Relatively straightforward to collect specimens and diagnose, and both can be done with hospital-based surveillance. There are big differences too. Influenza affects all age. I think one of the great things about rotavirus is it was simple. It was just children under 5 was the real focus. The proportion of illness among people who are hospitalized is likely less dramatic than it was for rotavirus. I mean, for rotavirus, we could say, almost half in some cases of children presenting for care with diarrhea were due to rotavirus, and that's an impressive percent. It's not quite so impressive for influenza. The influenza attributable fraction can be difficult to determine because it's not always pneumonia and influenza-like illness that might cause hospitalization or mortality. There are no sensitive antigen detection assays, which rotavirus did have, whereas we have to rely on PCR for flu, at least to get reasonably sensitive estimates. Clearly, the current vaccines are yearly hit-and-miss vaccine in the sense that it may or may not be a match, and it has to be every year. And the other thing that drove, of course, the ADIP was the fact that there was a promise of a subsidized vaccine at the end of the process, and Gavi subsidizes many countries for their rotavirus vaccines and continues to. So this is my last slide, just to sort of say, influenza ADIP, question mark, is it appropriate model or not? I think these are just a few things I just jotted down, but I think, as has been said before, there'll be a different focus for different countries. By no means are all countries going to be giving seasonal vaccine to everybody of all ages every year. But I think we do need to go ahead with some sort of determining the burden of influenza globally through surveillance, perhaps using vaccine probe studies to get by some of this issue that some of the disease is not obviously attributable to respiratory illness, or some outcomes are not obviously attributable to influenza and respiratory type symptoms. For poorer countries, we should be focusing maybe just on children and saying, let's look at under 5 morbidity and mortality, and let's see if a vaccine there can help using novel vaccines and novel strategies. Live attenuated vaccines in young children, will they have a broad, long-lasting immunity that will be sufficient to protect children for as part of the EPI schedule, protect them up to the age of 5, universal vaccines, adjuvanted vaccines, maternal immunization. These are all things. Intradermal's not here, but that would be another potential dose-sparing strategy. So I leave it with that, and perhaps we can have a discussion later on. Thank you very much.
Thanks very much, Mark. And like the other sessions, what we're going to do is go through the scheduled talks, and then we'll open it up for question and answers. So I don't know how to get your talk up here. Actually, is your talk on this computer?
It should be.
Excellent. So our next talk is by Dr. Lois Privor-Dumm, who is the Director of Alliances and Information for the International Vaccine Access Center at Johns Hopkins, and will give us a talk about the Pneumo ADIP, the other ADIP that was created a few years back. And if you can find your...
Okay. So while I'm looking for my slides,
It's up on the screen, so I don't think it's running on that screen.
Oh, so how does it get running here? Well, Okay, so do I just tell you next?
No, you can use this.
Oh, I can use this.
But just
Okay.
just like this.
So I don't pay attention to that.
We know what we're doing.
So, thanks for the opportunity to come here and talk to you a little bit about the experience with pneumococcal conjugate vaccines. Like Marc-Alain described, we are also an ADIP sponsored by the Gavi Alliance and have gone through a very similar process. I'm not going to touch too much on the surveillance aspects. There were a lot of challenges there for pneumo, just as they are for any vaccine. But what I'm going to do is talk about some of the other approaches that we took to generate demand for vaccines. So in order to do that, I think it's good to start with what was the environment when we started, and why wasn't there the demand in developing countries for pneumococcal vaccines? And in 2003, when our group was first put together, there was an environment where there were pneumococcal vaccines which were launched in 2000 in the U.S. No developing countries really had any intention at that point of introducing the vaccines. I think the thought was it was just too expensive and that it would never come, that there would never be enough supply. I don't know if any of you remember in the early years of pneumococcal vaccine, there were also a lot of supply issues. So there was no financing committed to the vaccines. They were considered expensive. The price at around $60 a dose. I think it was 58, somewhere around there. No WHO recommendation, and the developing country markets are largely driven by what WHO says. They want to know that there is significant disease burden, that this makes sense for the countries, that they have a way to implement it. And the other major factor that we faced was that every country wants their own local data. And for pneumococcal disease, although there have been a number of studies, they're very limited. And many of the studies were of not sufficient quality to be able to draw conclusions, or if they did draw conclusions, it may have indicated that disease was not sufficient. And the one missing piece for us was the serotype data. So it wasn't enough to only have disease burden to say how much pneumococcal disease was. We really needed to know what the serotype distribution was, because the thoughts were that the existing vaccines, and the existing vaccine was a 7-valent vaccine, would not sufficiently cover the serotypes in the country. So in determining how to move forward, we had to take a look at who are our stakeholders and what type of solution space do we want to see. What is the answer? What do we need to make happen to see pneumococcal vaccines reach the children that need it most? And the first thing we had to do was have industry that's willing to supply. As I said before, the pneumococcal conjugate vaccine was in limited supply. It's a difficult product to manufacture and develop, and we needed to ensure that there's more suppliers out there and those that were willing to supply the product at reasonable prices. The next thing that we had to make sure was that there were countries that were willing to introduce. And this was not an absolute given. Even though I think it was well understood that pneumococcal disease was a problem, they needed to be convinced that it would be worth the price that they would have to pay. And the perception was out there that the price would be a fairly high price. And then finally, you needed donors and countries willing to pay. And I put both donors and countries here because in this case it is a shared burden. The cost of the vaccine is probably, even at a low cost, going to be too high for most of the countries that we're working in. So it does require donor support. But one of the things that we wanted to see is that these vaccines were not provided for free. There was a previous model and previous situation with Hib vaccine where initially the vaccines were provided for free. And the conclusion there was that that's not the best case, because you don't get the commitment from the countries, and then the countries are saying, well, what happens if donors stop paying? I'm not going to put myself in this situation. So that's the situation that we were working towards. So our group, the NUMO-ADIP, worked in essentially 3 different areas, as well as project administration, which is important for any product. So the first area is research and surveillance, and as I described before, the main focus is to ensure that we have disease burden, but not just at a global level, but that we can describe it at a local level. Now, this was somewhat of a challenge. We also needed serotype data, and serotype data, again, at a local level. Easier said than done, but there was a major project that we worked on, the Global Disease Burden Project, with our partners at WHO. It was a WHO-led project. We also worked with CDC on this project to be able to describe the burden of disease for both pneumococcal disease and Hib disease, as well as the various syndromes. And this was brought down to a country level. Now, one of the challenges here was that it was modeled data. So countries always wanted to hear about, the studies that were done in their countries. Many countries were not able to use their local data to determine disease, and what we had to do was go through a process to be able to educate the epidemiologists in the countries, the decision makers, policy makers, etc., to explain why modeled data was preferred. We also went through a global serotype project to be able to describe what the likelihood of a particular vaccine was to cover the majority of the disease that existed in the country. In the area of advocacy and communication, this is a part that's often underestimated by projects moving forward, and something that we found to be very, very critical to generating demand, not only in the countries, but also convincing donors that this is an important area to support, and the suppliers convincing suppliers that the demand would be there when a product actually reached the market. And, putting all those pieces together and coordinating it is very challenging. And the process of communication, as well as developing advocates that are going to be out there and moving the process forward, was very critical. Vaccine access and implementation was an area that was also seen as very important. A lot of the activities here involved forecasting, and that's an activity not to be underestimated. Not only just generating the forecast, but having the ability to take a look at what is behind the forecast. What are the assumptions that have to happen? How do we know? I actually came from industry originally and was sitting on the other side of the table questioning, well, how is these numbers generated? What is the plan to actually get there? And why should I believe that these forecasts are going to actually materialize? So that's an important process to go through, the communication of what is the plan and who is ultimately responsible for making sure that that plan is executed. So some of the things that helped us in our process were having transparent assumptions, having a lot of stakeholder input, and recognizing that stakeholders come from various parts, that it's not just the governments, not just donors, not just partners, but you need to reach out to a number of different groups that also influence the whole process. And each vaccine is going to be slightly different, but there's civil society out there, there's the manufacturers and other groups, as well as the media, that want to be hearing about how is this process going, and constant communication is something that helps, as well as it's something that provides input for you to be able to adjust your plans. We also made sure that our messages were targeted towards the people that we were talking to. And down at the bottom, this is this is, unfortunately, it's only a short 15-minute talk. This is a lot of the work that went into what we did to generate the demand for pneumococcal conjugate vaccines. We didn't do it alone. We worked a lot with partners, and I think partners are really, really critical in this process. The first group is PACE Pneumococcal Awareness Council of Experts. They're a group of experts around the world. Many of them are pediatricians. They're respected experts in their own countries. And this is a group that it's a multi-country group that has come together to talk about the importance of pneumococcal disease and advocate for the use of a vaccine. Now, this group does a lot of different activities, from holding conferences to holding press conferences to writing op-eds. Many of the members will go and visit their political leaders and talk to their political leaders, and it's a coordinated way to get across that this disease is important and that something needs to be done about it. The logo on the right is the All-Party Parliamentary Group in the UK. Now, this is a group of parliamentarians from different political parties that, again, are coming together and saying that we can't ignore the need for pneumococcal vaccines. And this was a critical tactic in helping ensure that there was donor funding, showing that there were governments out there that are willing to support these vaccines, that place importance on it, and say that it is the right thing to do. It's something that has influence beyond just the UK to other donor governments, as well as other country governments, developing country governments. And then the third group that I'd like to highlight is also a coalition. And this is a newer effort, one that we started just last year, and it involves over 100 different coalition members coming together to talk about pneumonia. One of the things that I want to talk about just for a couple of minutes is that when we first started our project, we started talking out about pneumococcal disease. We soon found out that although there were a lot of advocates that are very concerned with the disease, we really had to broaden our focus. And a lot of the people that would support introduction of different interventions are not in the vaccine world at all, or may not be in the pneumococcal world at all. And so we found that talking not only about pneumococcal disease, you can't escape talking about that, but talking about the broader problem of child pneumonia and the broader problem of child survival was really critical. So what this effort did was it joined together different groups. It joined together civil society, it joined together various partners, country governments, and a number of different stakeholders around the world. And we had activities in 25 different countries in the first year to talk about the importance of pneumonia and the need to move forward to do something about this disease. Now, moving forward and doing something about it was not only just introducing new vaccines, but it was in ensuring that antibiotics were reaching the children that needed it, ensuring that mothers were breastfeeding and that there was good nutrition, and ensuring that the systems were in place to make it happen. So finally, where are we in 2010? We now have an advanced market commitment, $1.5 billion coming from 6 different donors, as well as it was essentially matching support from the Gavi Alliance. We have, and this is something that I think many people didn't believe would ever happen, but for manufacturers, including both multinationals and emerging market suppliers, have now come to the table and said that they are going to be providing pneumococcal conjugate vaccines. That the other important part is that we're not talking about the 7-valent vaccines anymore, that we did the work to ensure that we're providing the vaccines that are needed by the country and that are appropriate for the country. There is a WHO recommendation on pneumococcal vaccines, and a very strong recommendation. Those recommendations hold a lot of weight, but a recommendation in itself is not enough to make things happen. There also needs to be people down on the ground communicating those recommendations and advocates really reinforcing those messages. So where we are today is 13 approvals from Gavi countries. So 13 low-income countries are planning on introducing the vaccine within the next year or so, and then 12 more that are awaiting approval. This is out of a total of 72. Our efforts don't focus only on low-income countries. A lot of our advocacy efforts also are going towards middle-income countries as well as donor countries. So, but we essentially, from the approval standpoint, are focused on the low-income countries. The results, I think, are very clear. It's death averted, and the deaths are in the millions, so that's pretty substantial. We're really proud of what we've done. We haven't done it alone. I think the key is to do it with a lot of different partners, and I thank you for your attention.
Well, thanks for those two great talks. I think we heard nicely two models of how we might approach influenza and building the case for influenza vaccine. I think these two models, these two programs, have been wildly successful by any metric, and I think have lots of lessons. I'm going to take moderator's prerogative before I open it up to general questions and answer to do two things. First, there's a couple of people here, Roger Glass and Kathy Newsel and others, that worked on rotavirus ADEP. And I would ask them, either of them that wants to speak or both, if they have any comments, lessons learned, advice for the influenza crowd in the room that they might share. They're struggling over a microphone right now. So.
Well, we owe a lot of debt in the rotavirus community to Dr. Glass, who really pushed rotavirus and its importance before the rest of the world recognized that. So I was hoping he'd go first, but we'll save the best for last on this one. Just to comment, having gone from influenza to rotavirus and back to influenza, there actually are some other similarities in addition to what Marc-Alain pointed out. And this is true for pneumo as well. One is that influenza causes a relatively nonspecific clinical syndrome. So when you get on the ground, in terms of building demand on its own, it's easy to recognize measles. It's relatively easy to recognize paralytic polio. And a healthcare provider and a parent can feel very good when they give a vaccine and see that their child does not get that disease. We're talking about syndromic illnesses now in these children, acute respiratory disease, acute diarrheal disease, very common, number 1 and 2 killers of children in the world. And so even if we implement pneumococcal and rotavirus vaccines, we will still have respiratory disease and diarrhea. So it takes a much more specific and targeted demand generation to show what percentage, as you said, Marc-Alain, of these broad categories of very serious diseases are caused. And also, I would say, it's not just percentages, but it's absolute numbers. And if you look at the absolute numbers of flu, we believe that they are likely high, as Abdullah Brooks and others are starting to show in the developing world. And in regard to financing, if we look at Gavi, who has been critically important, we know, for other vaccines and certainly for pneumo and rota, when they had their recent strategic planning for future vaccines, influenza was not even on their list. So pandemic influenza people think about, but annual influenza and the burden that it causes in children, in pregnant women, and in other vulnerable groups is not on people's radar screen yet.
Thanks, Kathy. Roger.
Thanks, Joe. I make a couple observations. One is that this whole program wouldn't have gotten going without Bill Gates' involvement. He saw the early disease burden data from the 1993 World Development Report. He invested in the Rota as the first vaccine he was interested in, along with pneumo and the children's vaccine program. He got the Gavi going and the ADIPS going, so it was without his strong support, we never would have been here today. The second is that the rotavirus surveillance started with precious little money and very little attention. And so the surveillance was not ideal, but it generated a whole group of people around the world who could advocate for the program, who were in centers of excellence in their own capital cities, and could do a lot to count the disease burden in their own countries and internalize it. I think that's a lesson for the flu folks, to know exactly what's the burden of flu and how to push for it. I would third say that here we are 8 years after the ADIPS began. We started with over 500,000 deaths from rotavirus. We still have over 500,000 deaths from rotavirus, despite the fact that the vaccine's licensed in over 100 countries. And why is that so? One is that we have, despite the 8 years, we have precious little data about efficacy, and I think Kathy Newsel has done great things to push the efficacy data and the studies in the developing countries. That said, the efficacy of live oral vaccines in poor developing countries has been less than it's been in middle-income countries. There's a research agenda that we have to address to understand why that is so and to overcome it. So one is to improve the efficacy, which remains, even though using vaccines that are half effective could have a major impact on mortality. The second is the issue of cost. And while the cost in the middle-income countries now, and for Gavi, is a tenth of what it is in the high-income countries, the tiered pricing, we still have a way to go to make that affordable in the long term for the poor developing countries. And we hope that by having local manufacturers involved in vaccine production, we will have vaccines that are made at a target cost that's less than $1 or $2, as opposed to the prices even to the global health sector. So cost is one, efficacy is the second, and I would say that openness of data, because we've had data on the mediocre efficacy now for 6 years, but it hasn't all been public. And I think that the U.S. government has taken a position that efficacy data has to be, and clinical trials data has to be made public within 9 months of completing the trial. That hasn't been the case with some of the rotavirus vaccine studies, even though they've been done with public sector money. And I think that change will be welcome to all. So the good news is we have 2 vaccine candidates and companies with vaccines that are working well in much of the world and are licensed all over. We really have products, and we have a lot to learn from their intervention. The bad news is we still have 600,000 deaths a year, and we're about to hear the first data on reduction of mortality in middle-income countries. 85% of the mortality from rotavirus is in those low-income Gavi-eligible countries where the efficacy is likely to be substantially less, and we still have a research agenda to get more effective vaccines and more economical vaccines that can be sustainable for the long run. So thanks very much.
Thanks very much, Roger. That was perfect. By my watch, Daniel, we have about 10 minutes for questions.
Yes. And I have one.
Hold it. I think there was, before you, even though I think Dr. Shapiro first, then Daniel second, if that's okay.
To defer to Daniel if you would like to go. This actually is maybe not a question for the folks here up on the dais, but maybe people who were involved in discussions with Gavi about influenza vaccine. I think Rogers rightly credited Bill Gates and Gavi with all these activities of introducing new vaccine. And I don't think you could declare success regarding hepatitis B or Hib or even the activities with Rota and pneumo without the support of Gavi. I know that there have been some previous discussions regarding influenza with Gavi. I think I haven't been involved in them and don't know actually the results of those discussions, but I believe there was a discussion a year or two ago with the Gavi board about having Gavi support pandemic flu vaccines or pre-pandemic vaccines. And I'm just curious if any of the people in the room here were involved in some of those discussions, and what was the response from Gavi? Why are they not supporting, for example, establishing pre-pandemic vaccine stockpiles? Was it the fact that it wasn't the age group that Gavi normally deals with? Was the data that Dr. Ruiz talks about, what did they feel was not available? I'm just wondering if anybody in the room was aware of those discussions and know the rationale behind the feedback from Gavi.
Kathy, anybody that...
Okay.
I'm sorry? Marty Paul, of course. See you over there.
Yes, there were discussions with Gavi, and there were several options that were proposed to Gavi for an involvement into pandemic preparedness. So among those options proposed were participation in the financing of a stockpile, but also financing of increase of seasonal vaccine uptake in these countries, in developing countries to push demand. Gavi was not receptive to this idea, and there were several reasons, as mentioned by Craig. Among those, the fact that Gavi sees itself as being established mainly in terms of childhood vaccination. They didn't see influenza as one of the most important diseases as compared to rotavirus and pneumo. They also thought that in view of their constrained resources, indeed, many of us who are involved with Gavi know that they are currently into very, heavy pressure in terms of the financial crisis. They are not able to fulfill their current commitments, so therefore they didn't think that it was the time for them to engage into influenza and welcome the participation of other stakeholders.
Thank you very much, Marie-Paul. Dan?
This is a question that reflects my ignorance of the ADIP process, but who in the rotavirus, I heard in terms of the rotavirus that it was instrumental, the Bill and Melinda Gates Foundation interest and support of that. In process-wise, who is the funder? A funder who begins the process? Is it is there some institutional review process, or how does one engage in initiation of an ADIP-like process for other vaccines?
I can try to answer this, and then everyone else can correct me. There was, in, I want to say 2002, 2003, thereabouts, Gavi issued a call for proposals to establish a site for an ADIP. And so the call was a public call, and people applied for this. Consortia of institutions applied for this. And so, and one award was given out for pneumo and one for rota. So it was a very sort of formal, above-board process. And it turns out that both successful grantees were groups of institutions tied together that shared their particular skill sets. Is there anything else anybody wants to add? It was a normal funding opportunity announcement by Gavi, and Gavi provided all the funds for the ADIPs initially. Kathy?
Joe, just to take it back further, I think Roger pointed out it was an initial grassroots effort that even brought it to the attention of Gavi, I would say, to get it to that funder's level.
Indeed, that's absolutely true. Thank you. Other questions? Abdullah?
Just to recap just some of the points that were made, because I think Marc-Alain very nicely illustrated some of the differences in the challenges faced introducing, let's say, a pneumococcal vaccine or a rota vaccine versus an influenza vaccine. And the importance of, I think everyone has already stated before, of having good data. I would argue that going forward, in the absence of an ADIP, whether or not influenza needs an ADIP to help bring this more to developing country demand, I think three things, at least to me, stand out, or three types of data stand out. One, really are not only data on disease burden, but specifically the issue of the broader question of childhood pneumonia. I do think that for developing countries, that is the question. They do face that. They are making difficult choices about what cocktail of vaccines to introduce. And right now, I think there's general consensus that we don't have a complete understanding of all the etiologies behind childhood pneumonia. We can explain up to 50% on a good day, but the other 50% we cannot explain. And I think we need better data, particularly that the contribution of influenza to childhood pneumonia. So one is disease burden data, but syndromic data tied to lab-confirmed influenza. Second, we've discussed yesterday the importance of having good post-vaccine introduction surveillance, and I think that's going to be crucial because vaccines like this are introduced at a time, speaking as a pediatrician, at a time when many other childhood diseases begin to manifest themselves, importantly among those convulsive disorders. So it's important to have good quality data to robustly refute concerns about the safety of the vaccine post-introduction, which can cause donor support and other collaborative support to wane if there's a perception that the vaccine somehow is making things worse. And third, I think Roger Glass and Kathy Newsell both pointed out today, and Kathy and I were talking about this yesterday, there is a perception often that the vaccines that are introduced appear to have a different efficacy, oftentimes substantially different efficacy in developing countries versus in developed countries. And often people fall back to, forgive me, but hackneyed explanations of differences in immune status and overall disease burden and so on. A lot of this, though, comes down to study design and having good, carefully acquired data that really are comparable, and often these data are not comparable. And I think it's important, again, as we think of post-vaccine introduction or even efficacy trials, to pay attention to study design so that we really are comparing apples to apples. And when we look at efficacy and making sure we have common endpoints, common definitions, so we really can compare what the efficacy is. Again, keeping our eye on the ball and focusing on the issue of childhood pneumonia, so that we really can say, yes, we have comparable or non-comparable impact on disease burden.
Thank you. We have time for one more question. Maybe. Let me just ask, let me spend the last 1 minute and ask one question, either of our panelists or of anybody else in the audience who has an opinion. One of the issues that came up in both ROTA and the pneumo, as was mentioned, ADIPS and a lot of other things, is whether every country needs their own data, and because the answer to that really drives a lot of the resource utilization for the ADIPS. How much money do they spend in countries? How much modeling do they do, et cetera? For flu, in countries interested in influenza vaccine, either expanding or introducing, do they need their own data? Can we use data from one country to estimate flu burden in another? Any opinions around the room, or maybe among the panelists first? Yes.
If I could just comment, one of the things that we found is that the desire for countries' own data often slows down the process, and I think one of the things that needs to be weighed is just that. Can you look to another country and make a decision that's based on a rational set of arguments and points, or is it that the epidemiology in your country may be truly different? And that was something that we struggled with quite a bit, and the whole purpose of the Disease Burden Project was just that, to be able to summarize the data that was going on in different countries, because what countries had was very little visibility to studies that were done in other areas. The other thing that we found in our experience is that oftentimes there were studies at various universities or various groups that may not be directly involved in the government process that are not necessarily known, and having a group or somebody that is specifically asking questions to find out what data actually exists is something that could be very helpful.
Great. And Mark, final word, if you...
No great pearls of wisdom, but just to say, I think that for influenza perhaps is getting good quality data from sites that can do it well, at least in the initial phase, and then before before overstretching. I think we have the idea of networks. I think that these are important, but we also want to get the ball rolling if we're going to be looking at disease burden data, and sites such as Abdullah's in Bangladesh and others that can get really good quality data is probably where a lot of the effort should go. As the ball gets rolling, then to expand the sites.
Great, thanks. And I think we better move on now. Dan, since you run the meeting, you can get one last word.
Actually, I just wanted to provide, we probably need to find the appropriate balance between country-specific data and learning from the experiences of similar countries or other countries. Remember that when it comes to national policies, you have to keep in mind who the audience is and how receptive they might or might not be to experiences from other countries. Having worked in the former Soviet Union in the early 90s, our experience was that there was a lot of pushback in terms of the experiences in other countries are not applicable to the specific countries we were working in. And so I think that you really need to, once again, do your market analysis in terms of who's your audience and who are you trying to reach and what kinds of information are they going to need, and work backwards from there. You may be able to use data from other countries. You might need to make some effort at least to get some relevant data from the country itself.
Thank you very much. And so with that, let's move on. Thank you again to the speakers for wonderful talks to start the session.